Hujambo Espresso Talk Today community. It's Amma Robin here. Akwaba to the Espresso Talk Today show. Welcome to the Espresso Talk Today show. Thank you so much for joining us today for this uncommon conversation. Today, the Espresso Talk Today team is meeting with Dr. Clyde Yancy, an amazing cardiologist, researcher, and scholar. I'm going to tell you more about him in just a minute. This was our first meeting with Dr. Yancy, and the ETT team had a lot of questions. And Dr. Yancy was gracious enough to spend considerable time addressing and answering these questions for us. Dr. Yancy brings a wide range of knowledge and experience to this conversation about cardiology and promoting heart wellness. So, we are going to tap into as much of that knowledge and experience as time permits. We really did, actually. Mel will arrive in just a minute. Then we're going to get started. While we wait for my esteemed team member, let me tell you a bit about Dr. Clyde Yancy. Dr. Clyde Yancy is a cardiologist and professor of cardiology and a professor of medical social sciences at Northwestern University Feinberg School of Medicine. He has previously served as president of the American Heart Association, and he remains the national spokesman for the American Heart Association. Dr. Yancy is the Vice Dean of Diversity and Inclusion at the Northwestern University Feinberg School of Medicine, and he is board certified in both internal medicine and cardiovascular disease. Dr. Yancy is also a member of the Association of Black Cardiologists. Now, Dr. Yancy's research focuses, as you probably have guessed, on heart failure, heart transplantation, and this is a really important one for us, ways to prevent heart failure. I did a little extra digging. It wasn't hard, and I found that Dr. Yancy's patients describe him as brilliant, compassionate, an excellent listener, and an incredible human being. I was not a bit surprised. Mel and I had the exact experience and feeling about Dr. Yancy, and we're so happy that we can share it with you today. We originally contacted Dr. Yancy to discuss one of the deadliest and most disabling illnesses experienced by African Americans, heart failure. We actually had a very enlightening discussion about heart failure and other cardiovascular diseases, but Dr. Yancy went far beyond the discussion of heart failure and into areas where many doctors just simply don't fear to tread. His courage and candor, and yes, his compassion, were expressed throughout this discussion of these scary diseases like heart failure. But he really did take it so much farther. You're probably thinking the exact same thing as I am. Wow, wow, wow. Yes, Dr. Yancy is an amazing doctor, and people actually think of him as the physician's physician. That's amazing, isn't it? He is doing incredible research about cardiovascular disease and cardiovascular health and wellness, and he was so generous with his time and energy and expertise. Did I mention that he's also received numerous awards for his volunteer work? Okay, well, I've mentioned it now. So he gave so much information to give to you. He wants you to have this information. He wants all of us to. Now, this is a doctor who is saving and uplifting lives, and we are so glad that you're here with us to learn about heart health and heart disease from such an experienced, knowledgeable, and committed physician. Okay, I'm going to stop here. You can hear it all for yourself. We have a great and uncommon conversation for you today. I'm sure you've heard that now. Spoiler alert, this is the first part of the conversation. We will continue and conclude the conversation next week, and you definitely do not want to miss next week's show. We're going to get into heart health next week, but more about that after the show. Mel has just arrived, so sit back, relax, Grab an espresso or a cup of tea if that's your preference, and let's get started. Hey, Mel.
Hi, Robin. How are you?
I'm doing really well. How are you today?
I am fantastic.
I can see that, and you always are. And as you can see, I am having an espresso with a very special guest. This is Dr. Clyde Yancy, professor and chief of cardiology at Northwestern University, Feinberg School of Medicine, among other positions too that he holds there. And you're going to hear about a lot of that. So I've already introduced Dr. Yancy to the Espresso Talk Today community, but Mel, please let me introduce Dr. Clyde Yancy.
Hello, Dr. Yancy. So happy to meet you.
Hello, Mel, and hello again, Robin. Boy, how nice is it to have an opportunity to meet the both of you? And you have espresso, I have dark roast, so I'm delighted to have this conversation with you.
Thank you. We're so happy that you're with us, and welcome to the Espresso Talk Today podcast show. And Asante Sana for participating on this show. Thank you for being on the
Oh,
show.
nice. Thank you. Let's get going.
Okay, we're
Yeah.
fortunate to have you here. And let's see, I like to open the show, almost everything, with a quote. And in preparation for this show, I read a statement that you made in an address at the annual meeting of the Heart Failure Society of America in 2019. You said, there are real differences in the experience that African Americans have when they suffer heart failure. And that's quite a revealing statement to make. And I wonder if it also applies to cardiovascular disease in general and a stroke. But I'm going to ask you about that in a minute. But that statement does set the tone for today's show.
So
Um,
it's so remarkable that you captured that statement because that statement is applicable to heart failure as a specific disease, applicable to cardiovascular disease, but also it's uniquely applicable to health. And that statement is really anchored on over 25 years of my own investigation, research, observation, and writing. And so, if you will, you got to the bottom of the funnel very quickly. There were a lot of other data inputs that mattered here. But in the context with which that statement was made, there's been a disease entity about which many of us are aware, many family members for you, for me, particularly in the African American community, have experienced this condition known as heart failure. And in a more global sense, when we think about heart disease in particular, we are aware that many of the published data points from all over the world describe a very different experience of health and disease as a function of race or ethnicity, but importantly, not necessarily because of race or ethnicity. Let me be clear about that. What I'm suggesting to you is that there are crude descriptors of the patient experience that are approximated to race or ethnicity, being Black or non-Black, being Hispanic, non-Hispanic, etc. But what we have devolved at this point in our understanding of disease is that very little, maybe even zero, of the root cause of those differences in disease are uniquely attributable to race. So this gets us to the singular concept that really drives contemporary discussions about race-based experiences in health and race-based experiences in medicine. That is to say that race is limited to the social construct, that is the life and living experiences that impact one's health and as well, or in turn, the disease state. But there is very little about race per se that causes the disease. That's a step forward because not so long ago, the very common statements were Blacks suffer disproportionately from this, or Blacks have this condition, or Blacks are at greater risk. We recognized then that that language per se was using race as a very crude, indistinct placeholder for something that was more pertinent in understanding the genesis of the disease. Now, I'll stop my comment here because we need to have a longer discussion about this. But I'll just say that when we think about this history of race-based medicine, we can partition that history into the very small amount of health and disease that is related to our individual ancestry. And I say our because I am an African American self-described professional. So, to the extent that we track our ancestry to African heritage, then there is a small amount of disease that may be associated with African heritage. Beyond that, everything else becomes either a recognized contributor to disease, like obesity, diabetes, hypertension, and behaviors like smoking or physical inactivity, or they're related uniquely, and this is where the conversations become awkward for some, but uniquely to the inequity in life and living, to the bias in life and living, to the structural systemic barriers to the attributes necessary for health and necessary to avoid disease. And some would approximate all of that to the underlying presence of structural racism, which has been present in the United States now for centuries and is still evident today, that there is some residual effect. There's a lot of argument in this country about this latter concept, and there are those that stridently push back, but the data speak differently. So that's a long preamble to say that for a variety of reasons, there are differences in the way in which persons that are self-described as African American experience disease and or acquire health, but those differences are driven by a number of very important complexities.
Hmm. So basically, you're saying that race and racial stress or racism, those are different factors, and we experience them differently. Of course, race is the way it is, but racial stress can be a risk factor for uh, for heart failure and other diseases like cardiovascular and stroke.
So, Mel, I like the way you're going with this because it's the latter that not only is the more pertinent discussion, but it's the more actionable discussion.
Mhm.
Race is a convenience sample. It is a labeling of individuals according to a socially derived model.
Mhm.
To think that skin color infers a sameness in biology when one understands that skin color is the amalgam of so many different inputs, meaning to say so much intermarriage. Think about persons that are from the Caribbean, think about persons that are from South America, think about persons that are from Africa and different regions of the continent of Africa. Africa is not a country, it's a continent. And so you begin to understand that it would be very, very difficult to invoke a certain sameness in biology just because of skin color. However, the way in which groups have been treated systemically over the last 2 centuries changes that narrative. Whether it's the perpetual experience of persons that have a history of having been enslaved, living in communities where slavery was deeply infested, if you will, in those communities. Whether it's persons whose acculturation included an environment where segregation was active, whether it's persons in a more recent time era who were living in communities that were disinvested, not invested, but disinvested because of the disproportionate clustering of certain groups of patients that were patients, I'm a physician, people that were not favored by municipalities, by public policy. So it's a very careful discussion. But what we've learned over time is that because of your life and living circumstances and all the things that go into that, economics, access to healthy living, to safe living, education, transportation, all of those things that, if you will, are the floor of life. You understand that some people have a solid foundation of life and
Mhm.
some people have a wobbly foundation of life.
Yeah.
And that has much more bearing on health than we've ever appreciated. I can make this even simpler. Turns out that your zip code now is as important as your genetic code. when we're thinking about health and disease.
Wow. Wow. I know we want to continue on with this, and this is really important, but I think we need to back up a little bit, okay, because maybe we did start at the bottom of the funnel. What is what is cardiovascular disease? And heart failure is a scary term to hear. Can you explain that too, doctor?
So let me deconstruct that, because both of your observations are necessarily a requirement for us to further expand. So cardiovascular disease continues to be the leading cause of death and disability in industrialized countries. That is because of our Western lifestyles, which are predominant throughout industrialized countries. So that reflects the convenience of food prepared outside of the home. That reflects the ubiquity of certain lifestyle choices, smoking, physical inactivity. It reflects the burden that appears to be not ending of obesity, and along with that, diabetes. These are characteristics of a Western lifestyle. The consequence of that lifestyle then is a predisposition. It's a word we like to use in medicine, but from a lay perspective, it means a vulnerability to developing diseases of your blood vessels. I want to be very clear that I said diseases of your blood vessels, because that really qualifies the next statement. Whether it's heart disease, brain disease, or kidney disease, it all starts with this risk factor burden, with a slight upload from your genetic ancestry, but it starts with this risk factor burden. That then leads to a greater likelihood of stroke in certain communities, a greater likelihood of heart disease, heart attacks, and heart failure. The two are not the same, and a greater likelihood of chronic kidney disease. So when you begin to think about this deconstructed view of the burden and understand that it tracks primarily the lifestyle, so much so that we can emphatically state that 80% of cardiovascular disease, regardless of the person, Black, white, European, American, doesn't matter, 80% is ostensibly preventable. That's how important lifestyle is in this conversation. So then as we move over into the second part of your question, that is thinking about heart failure per se, Robin, let me give you a shout out and two thumbs up, because you articulated with so many patients now that I see are afraid to articulate. Heart failure is a scary term. If I told you had kidney failure, a bone marrow failure, or lung failure, you would have this unnerving awareness of your own mortality. In the early decades of the recognition of diseases of the heart that led the heart to be weak, to not function as well, failure was the right terminology, in part because we had no therapies to make a difference. And we still face a burden of heart failure, but a burden of heart failure that has been enabled by a robust number of important discoveries. So much so that it is my quest now to share with audiences, particularly public audiences, that everything you think about heart failure, every experience someone in your family or you have had with heart failure, everything you read on the internet when you search for heart failure, take 3 steps: delete, delete, delete,
Okay.
because it doesn't reflect the contemporary context. The contemporary context gives us a definition. The heart has a structural change and capable of functioning as you need it to function so that you are comfortable you can do meaningful work. But in addition to having a structural change, there's already evidence that the heart is becoming inefficient. And there are ways that we can do that. There are simple laboratory tests that can give us that information, things we can do in an old-fashioned physical examination. I still use one of these, and for your listening audience, I'm holding up my stethoscope that's 20 years old, and it's the same thing I've used throughout my whole career, no matter what technologies I have. But I'm getting to a point. We know what the condition is. It's an abnormality of the heart that's associated with inefficient function of the heart. But we stop there because the way in which it is experienced by different groups, by women, by persons self-described as African Americans, by older persons, is sufficiently nuanced that a contemporary physician or care provider, thinking about an advanced practice nurse, for example, really needs to be facile with all of these different iterations of the disease process. So you're right, it is a scary term, but you can exhale and understand that the fear is no longer at such a heightened level. It is a topic of concern, something we need to respect, but it is not a fatality by definition. We can treat this condition and treat it well.
So how do physicians go about identifying that? You said that perhaps there are different ways of determining if a person has heart failure, but some physicians may not be familiar with the new nuances and the new therapies or the new diagnostic ways of determining that.
So Mel, you have moved into a different space.
Okay.
Robin wanted us to talk about things definitionally,
Okay.
if you will. But you're helping us enter into a discussion about implementation. How do you actualize this awareness of the nuances of heart failure? So just like I'm working with the two of you today, you, Robin, and you, Mel, to socialize perspectives on heart failure with your listeners, in a separate domain, me and many other professionals are working in the professional space to socialize these new narratives, to amplify the new discoveries, and importantly, to promulgate the new approaches. But one of the key considerations, nothing drives a physician's behavior more so than a patient or family member's question. And so by having this conversation with you and by allowing you to amplify my voice and let your listeners know, if you're experiencing the onset of fatigue different than what you've experienced before, if you're experiencing frank shortness of breath, if you see that your ankles are getting puffy, if you understand that you've got a persistent cough and you don't feel like you have a fever or a cold, these are symptoms that are not due to old age or just being lazy and tired. You should be functional well into your later years. And once you begin to see, I'm no longer able to walk a certain distance, or I'm getting up in the middle of the night to simply catch my breath, I find that I'm more comfortable sleeping upright in a chair because when I get in bed and fully reclined, I'm not breathing well. Not breathing well under any circumstance, Mel. Let me be very clear. Not breathing well under any circumstance, whether it's exercise or your position in space that is being lying or sitting, that's an issue. You don't just ride that out. It doesn't just go away. If you're not breathing well, that's the moment that you don't search the internet, you don't get on the computer, you get on the phone or you get in the car and you talk to a professional. Because there are many reasons why you might not be breathing well, but one of those is cardiac. And even the cardiac causes are not always heart failure per se, but it could be attributable to an irregular heart rhythm, or it could be attributable to blood vessel disease around the heart. But don't be your own diagnostician. Don't do that.
Okay, so if you're experiencing those things that you just mentioned, should this is a risk factor for possible heart failure, and people should go in and see their physician about that.
Mel, you're so prescient today because the risk factors how it all gets started.
Okay.
There's no mystery here. There's a trioca.
Okay.
Obesity, diabetes, and hypertension. I'm getting so excited talking to you because you're raising such a good question. So try to say diabetes and obesity in the same word. But diabetes, obesity, and hypertension, if you've got those three things going on, that is not a mystery. If you've got those three things going on and your older age and you start having shortness of breath, I mean, that's the flashing yellow light. Talk to someone because there's a chance there's heart failure. And oh, by the way, and this gets back to the opening comment, Robin, that same trio I just described, particularly when it's associated with shortness of breath, that awareness happens typically 15 years earlier in self-described Black patients than non-Black patients. 15 years earlier. Typically happens in the mid-40s to early 50s, while for everyone else, it happens in the late 60s and early 70s. Think about that. Earlier onset, more symptoms, a very compelling circumstance. And unfortunately, the epidemiology that we have tells us that part of that nuanced difference is not just in the social circumstances, not just in the life and living, not just even in age of onset, it's in outcomes, Robin, meaning hospitalizations are more frequently in self-described Black patients due to heart failure. And unfortunately, there appears to be still a signal of more deaths. I say that very carefully because there's so many qualifiers on that kind of information. Just the ascertainment of race from medical records can be very challenging. But the data appear to suggest that for certain, hospitalizations are happening more frequently. And if it's also a risk of death, that's a concern.
And you mentioned excuse me, Mel, some qualifiers. You say this hesitantly because there are some qualifiers. What qualifiers would you say?
So very good question. Quite insightful. I love that both of you were ready to speak right away because now it means I've got your attention.
Oh, you have.
But the qualifiers that are so critically important are first, what are the concomitant other illnesses? Robin, very few people show up with just one condition. They almost always show up with a heart condition, and oh, by the way, a kidney condition, and oh, by the way, high blood pressure. So trying to deconstruct what's really driving the outcome of concern, or conversely, understanding the synergy, unfortunately, of progressive renal disease, heart disease, hypertension. All of these, I think, have to be carefully addressed when we're trying to assign cause for something like death. And so we must keep this in mind. And I would be remiss, terribly remiss, if I didn't put in the same discussion not only the several other associated illnesses, the word I use is concomitant, but also make clear that access to care continues to be a troublesome issue. And it's not access to care like most people would define it. I'm pleased that most people in this country can present to a hospital and receive urgent care as indicated. But what concerns me about access to care is that we have a number of people who receive less care. They have access to care, but in totality, what they receive is less care. And it's that longitudinal care. It's that ambulatory care. It's walking in the doctor's office. It is, and this is the key word, Robin, it is that preemptive care that thwarts disease. It is that care that helps control the blood pressure, that helps manage the obesity, that helps control the diabetes, that helps facilitate the cessation of smoking. That is that undercare experience that we worry about. Yes, we have access to care, and I applaud that. But many people are in this undercare, not quite robust enough for it to, if you will, change the arc of disease. And that's important.
Wow, I haven't heard that term before, but undercare. Yeah.
So yes, you can put it in the context of, do you receive adequate care? If you are well insured and you're making all of your well woman visits and you're having occasional examinations, some would call them annual physicals. I'm not sure that needs to happen on a yearly basis. We might call that adequate care. What I'm suggesting to you, Robin, is that not in a very visible way, but there are innumerable patients on a large scale that instead of receiving adequate care are receiving something that is inadequate, undercare.
And so most of them are not getting the preemptive care, but they have access. If they come in presenting symptoms, then they'll be treated.
So
But
let me give you just a blatant example.
okay.
No one in this country with symptoms of a stroke will be turned away in a United States hospital. Your stroke will be treated and hopefully treated in a way that we can mitigate the consequences of a stroke. Medicine has come so far, and we can do that. But many patients with hypertension, a major risk factor for stroke, don't receive the adequate preemptive care, helping that patient manage the blood pressure assiduously, getting to a threshold of blood pressure control where the stroke risk is decreased. So think about the scenario I've just said. For that urgent crisis care, yes, you have access to care. Let's applaud. But for the really important care, the care that prevents ever having to present with the acute stroke, that's where this undercare or inadequate care or lesser care, use a synonym you enjoy most, but it's still the same phenomenon. We have a scenario where some people just don't get idealized care, optimal care to prevent disease. And that's not just for the stroke now. That's for the heart attack. That's for the onset of heart failure. Because let me just say, when a patient presents to the hospital with heart failure, that is scary. You used that word before. That is scary because you really can't breathe. You're in a hospital, and we know now with such great clarity, if you are hospitalized with heart failure, that is, your symptoms are so profound that you require hospitalization. That unfortunately is a negative pivot in your life. That changes your life expectancy. That changes your quality of living.
Mhm.
This is where we will stop for today. But this uncommon conversation is far from over. We're just getting started, but there's a lot to unpack already. First, though, Asante Sana to Dr. Clyde Yancy for discussing cardiovascular disease and heart failure with us today. Yes, heart failure is really a frightening term and it's a frightening illness. But I feel that Dr. Yancy gave a lot of hope about how it can be treated most effectively. Remember, he said that there have been, and this is a quote, a robust number of important discoveries about heart failure, end quote, and that the first three steps in learning about heart failure on the internet or from friends or from family are, first three steps are delete, delete, delete. His words, not mine. He described heart failure as a very nuanced illness. It's not a one size fits all disease, and every treatment will not fit everyone. African Americans, older people, younger people, women, we each have a different experience with the illness, and a contemporary physician will need to know the different presentation of the illness. Dr. Yancey concluded by noting, again quote, heart failure is a topic of concern, something we need to respect, but it's not a fatality by definition. We can treat this condition and we can treat it well, end quote. That's really inspirational. This is really great news, but we still must take certain symptoms very seriously and see a doctor. So what are those symptoms? Listen up, there are four. Here they come. Number one, fatigue. The onset of fatigue that's different from what you normally experience. Two, shortness of breath at rest or even if you're exercising. Number three, persistent cough without a cold or fever. And number four, swollen ankles. Pay close attention to these symptoms. Don't just write them out. Don't check them out on the internet. Don't be your own diagnostician. See your doctor. You might not have heart failure, but there might be some other cardiovascular illness arising. See your doctor as soon as possible. Dr. Yancy also discussed a trio, so 3 risk factors for cardiovascular disease. So do you remember them? Mel asked about them, and I'm so glad that she did, because these are risk factors that are really prevalent, that really exist a lot in the Black community. And actually, they exist a lot in Western society, as Dr. Yancy mentioned at the beginning of the show. So, what are the 3 risk factors? Number 1, obesity. Number 2, diabetes. Number 3, hypertension. So, obesity, diabetes, hypertension. So if you have one of these risk factors and you start having symptoms, shortness of breath, swollen ankles, persistent cough, unusual fatigue, see your doctor right away. Seriously, don't put it off. And if you're Black, these symptoms can appear 15 years earlier than for white people. For Black people, the onset of these symptoms can appear in the mid-40s. I mean, that's pretty young. And that's a time when it's easy to just ignore the symptoms and you're busy with other things. But please don't do that. Finally, Dr. Yancy discussed one last issue that's not often discussed. Many people, particularly Black people, are receiving inadequate medical care. They're receiving less care than their risk factors or symptoms require. This is called undercare. I had never heard that term before this discussion, but I can absolutely see how it affects Black health. Many people will discuss access to care, and that is an important issue, and it has improved in recent years, though it's still not quite at the level it should be. But undercare is when people do not receive the preemptive care that they need to stop the development of disease. Preemptive care will, for example, help a person to lose weight or stop smoking, and this reduces their risk factors and can stop the onset of disease. But undercare is present even when people have access to care. Undercare ignores or fails to address symptoms, risk factors, or lifestyle issues before they turn into disease. That's undercare. Dr. Yancy is very focused on preventing the onset of disease, and I mean that's the best way to treat, I think. Preemptive care supports this goal. Undercare is an obstacle to health. Okay, so what can you do? Well, good question. I'm glad. I like questions. You can reduce your risk factors. Take hypertension, diabetes, and obesity seriously. Take your symptoms seriously. Don't ignore swollen ankles or cough or fatigue or shortness of breath, or allow your doctor to ignore them. Think preemptive care. And here's a great term. Think idealized care. Wow, that is a lot for today. It's probably enough for today. I hope that you will agree that this is truly life-saving information. It's not often heard or presented, but it's definitely a game changer. But each person really has to do the work right along with their physician. We can help each other too, and we should. Encourage your friend to stop smoking or to lose weight, or work together to stop smoking or help each other lose weight. Help each other control the diabetes. Check on your loved one's blood pressure. Encourage your loved one to see a doctor if you notice that their ankles are swollen or that they appear to be unusually tired. Ask about your friend's persistent cough. Ask your friend about why they're coughing a lot or have a dry cough. We can help each other. Be gentle, but be firm. And most importantly, be willing to care and to help. We're in this together, so let's help each other. So that is all for this week's show. If you have any questions, please feel free to contact me at team@espressotalktoday.com or on Instagram at Espresso Talk Today. I also encourage you to check out the website of the Association of Black Cardiologists. They have great health-related information and a searchable directory that's amazing, so you can find a trusted Black cardiologist in your area. And you can find their information on the espressotalktoday.com website. Dr. Yancy will return next week to continue this important discussion. Dr. Yancy mentioned that 80% of cardiovascular disease is preventable. I got to repeat that. 80% is preventable. Well, next week, he's going to tell us exactly how it's done. There are 8 steps. 8 steps. They're called the Essential 8. And they'll be the focus of part 2 of our conversation with Dr. Yancy. You definitely don't want to miss that show. We look forward to seeing you next week. And again, I want to say a big Asante Sana to Dr. Clyde Yancy for sharing his valuable time with us to discuss cardiovascular disease and heart health. And I say Asante Sana to Mel and to you, dear community, for being in the building with me today. Dr. Yancy taught us a lot today, and as Maya Angelou once said, when you know better, you can do better. With this information, we can help each other better, help each other to take the steps to live longer and to live healthier lives. I'm Amma Robin for the Espresso Talk Today podcast show. And remember, y'all, strength, soul, and reparations. Ashe.